Good morning and welcome to Fountain Street Church. My name is Reverend Christopher Rowe, and I am the Minister for Spiritual Life and Learning here at Fountain Street Church. And on behalf of the Religious Services Committee who made this morning's service possible, welcome to worship this morning. This morning we are already at our fourth Summer Speaker Series service as we welcome Dr. John Sheagren to our pulpit this morning. As you can tell, I'm in our beautiful temple of love and joy and unity, and it's a little quiet in here, but sometimes that stillness is just what we might need. And so as you prepare your hearts for worship with us this morning, I invite each of you to find that still, quiet, and soft space within yourselves. Hold it and embrace it. And as you do so, remember again that you are welcome here at this virtual worship experience for Fountain Street Church. This is Fountain Street Church. I'm Christopher Rowe, and I am so glad you are with us this morning. Thank you for being here.
Have you ever fed a lover with just your hands? Closed your eyes and trusted, just trusted. Have you ever
When we worship together, the offering is a time for beautiful music and the act of giving a bit of ourselves back to the world. If I were sitting here on a Sunday morning, these aisles would be full of ushers passing the plate, and it's a tangible and symbolic way of committing ourselves to our community. Even though we can't readily do that here during this COVID series, we can still do it virtually or by sending a gift to the office. Every cent that you give of yourselves to this community goes back into our world, be it 50% directly through our missions or 50% through the operations that make this ministry and this legacy possible. So with the spirit of giving and generosity, and the spirit of the gathered community in which our distant and yet tangible gifts come together in one unifying gift for our world, the offering will now be taken.
Some days worry, some days glad, some days more than make you mad. Some days more than shine. When you see what's coming on down the line. Some days you say, oh, not me, never. Some days you say, bless God forever. Some days you say, curse God and die. And the day comes when you wrestle with that lie. Some days tussle and some days groan, and some days don't even leave a bone. Some days you hassle all alone. I don't know, sister, what I'm saying, nor do no man if they don't be praying. I know that love is the only answer, and the tightrope lover, the only dancer. When the lover come off the rope today, the net which holds him is how we pray, and not to gods unknown, but to each other. The fallen mortal is our brother. Some days breathe, some days bleed, some days you almost don't believe. Some days believe you, some days don't. Some days believe you, and you won't. Some days worry, some days mad, some days more than make you glad. Some days more than shine. Witnesses coming on down the line. Witnesses coming on down the line.
there's a stillness in this space. Though I am often lonely and sad by the emptiness of this building, I'd be lying if I didn't tell you that often I like to come into the stillness of this cathedral and just be for a moment. If you were watching a few weeks ago, you might remember the noisy construction work that was happening. And it's still happening right now, but you can't hear it. What do you hear right now? What do you experience in the silence? In the space of our prayer today, I offer you these words that actually come from a hymn in our hymn book. Find a stillness, hold a stillness, let the stillness carry me. Find the silence, hold the silence, let the silence carry me. In the Spirit, by the Spirit, with the Spirit giving power, I will find true harmony. Seek the essence, hold the essence, let the essence carry me. Let me flower, help me flower, watch me flower, carry me. In the Spirit, by the Spirit, with the Spirit giving power, I will find true harmony. Will you join me in being held in the stillness and in the silence? May each of us be held in the stillness and in the silence so that we might find true harmony. Amen.
All right, well, good morning. I'm Dr. John Sheagren, and I'm sitting in the summer room that my dear wife Victoria has added onto our house. It's got better lighting, it's a little cooler out here, and actually I brought in some flowers from the garden to make this a little more joyous than it may turn out to be. But the topic today is going to be the U.S. healthcare system, present status, and hope for the future. The reading I have today is from a lecture given by Risa Lavizzo-Mori, M.D., MBA, who is president of the Robert Wood Johnson Foundation. And she gave a lecture back in 2006 describing a man in his 40s who was a model for actually all of the modern academic medical thought processes that we're undertaking today. Dr. Francis Peabody was his name, and the speaker described him as an academic physician who had all the credentials of an early day superhero of internal medicine. Now, you all know that internal medicine is general medicine for adults, and as pediatricians are general physicians for children under the age usually of around 18. Dr. Peabody was the first chief resident at Peterbent Brigham Hospital in Boston. He also served at Johns Hopkins and the Rockefeller hospitals. He was a World War I Army field doctor and helped set up the first modern medical school in China, interestingly. He was founder of the Journal of Clinical Investigation, which is today the premier journal in which the best peer-reviewed research is published. But at the age of 45, presumably in the prime of life and the peak of his professional powers, he became seriously ill, incurably ill, cancer of the stomach. In those days, cancer of the stomach was one of the most common neoplasms. Not really clear why, but it may have had to do with the infection of the stomach by an organism called Helicobacter, and that has gradually faded, and we now know how to treat it. It's also related somewhat to diet. At any rate, out of the blue, this powerful, charismatic physician realized the end was near. And throughout the winter and spring of 1927, he delivered a series of talks about what it really means to be a physician. Medicine is not a trade to be learned, he told his students, but a profession to be entered. So the first slide is just the introduction, but here's the present status summarized. This is slide 2, summarized by the American College of Physicians. It is the organization for internists, both practicing and academic, which tries to lead the way in terms of the job description of the internist and therefore editorializes about the job descriptions of lots of other physicians as well, and you'll see that. So the present status, why does the U.S. need a better healthcare system? Well, do we? I think we do. Some of you may not, those of you probably who have good insurance and are very happy with your physician and so forth. But in general, this is the checklist of the issues that the American College of Physicians and I, as a member of that body, believe are problems. U.S. healthcare system costs too much. Right now, we're about 18% of the gross national product, pushing towards 20%. Actually, the Oracle of Omaha, I'm blocking on his name right now. At any rate, he described it as the healthcare system as the tapeworm of the U.S. economy. Now, if you know what tapeworms are, they're these long worms that live in your intestine and slowly suck nutrients and proteins out of your bowel. Very asymptomatic. People don't even know they have them until they begin passing pieces of the worm, and then they say, "Oh my God, what's happening here?" But one's weight begins to go down, and in fact, there's a story. I think it's true that in the 1800s they used to sell capsules that were weight loss diet pills. In each capsule was a larval tapeworm. And so people would take the capsule and 2 to 4 to 6 weeks later would begin to lose weight, and they were very, very happy. And unfortunately, they continued to lose weight and then began to pass the pieces of the worm and said, "What in the world is going on here?" This did not last very long, and I have to say, in all fairness, there was no FDA in those days, and they probably would not have approved this treatment. Costs too much, leaves too many behind without affordable coverage, creates incentives that are misaligned with patients' interests, undervalues primary care and public health. That's I put in bold because I'm going to come back as a main point here. Spends too much on administration at the expense of patient care, fails to invest and support public health approaches to reduce preventable injuries, deaths, diseases, and suffering, fosters barriers to care, and therefore creates and discriminates against people who do not have access to good medical care. And the pandemic has made that extremely obvious. If you are a little overweight because you can't get healthy food, if you have untreated hypertension, if you're overweight, you're then more likely to be diabetic. And once you get on a ventilator with those underlying risk factors, you have a large chance of not coming off the ventilator. So the ACP, the next slide, number 3, what to do. The ACP envisions a healthcare system where everyone has coverage for and access to the care they need, of course. Payments and delivery systems put the interest of patients first by supporting physicians and their care teams in delivering high value and patient-centered care. Spending is redirected from unnecessary administrative costs to funding coverage for research, public health, and interventions to address social determinants of health, which is huge in our country. Clinicians and hospitals deliver high-value evidence, which means evidence-based care. We'll do things because there are previous studies, controlled, randomized trials that show us the direction we should be going to treat serious illnesses. Primary care is supported with greater investment of resources. Payment levels between complex cognitive care and procedural care are equitable. Right now, just an example is if you are a surgeon and take off a little brown spot on your skin, you'll make between $150 and $300. A physician who works for an hour with a patient, a general practitioner or an internist pediatrician, spends an hour with a patient, might get $75 or $100 for that. You may say that's obviously your point of view, but it's pretty clear that the people who were at the table first when Medicare cost reimbursements were established were surgeons. And it was an amazing and certainly laudable issue that they were able to get into your body, remove or fix things, and yet the cognitive thinking about and dealing with patient issues, which is the primary issue of general physicians, internists, pediatricians, family medicine, etc., was not felt to be as valuable as being able to do a surgical technique. So primary care needs to be supported with greater investment of resources, and that the payment systems that support the value of internal medicine specialists needs to be increased. Incentives are aligned to achieve better patient outcomes, lower costs, and reduce inequities. There's nothing, this is where the devil is in the details, but we need to be able to say this was done well, and overall this yields a better return in the medical profession than other ways that money is being directed. Patients and physicians are freed of inefficient administrative and billing tasks. Value-based payment programs incentivize collaboration, so teams are going to be the key to the new healthcare system as it evolves. Health information technologies enhance the patient-physician relationship. Right now, they're there primarily to complete and make sure that billing is done in the proper way, and we need to enhance them so that one actually is able to judge the value of what the physician is providing to the patient. So to just start over in a brief overview of how we can achieve some of those goals, this next slide, which is the introduction, Dr. William Osler, 1849 to 1919, commented that the good doctor treats the disease, the great doctor treats the patient with the disease, because there's always individual variation in how disease is expressed and how treatments are planned based on the patient. And in the old days, as you'll see in some upcoming slides, the physician made that without having the inputs that we think we need from each patient as they enter this process in order to take the best care of that individual. Comment is borne out with some evidence that if you take time to ask people about their lives, which means asking them if they have a place to live, if they have social network, the sorts of things that show you're interested in them and you're not just treating their disease, they then join you in the effort that you're trying to do to make them better. You actually have improved their adherence to medication and control of chronic diseases tremendously. To move from a sickness model of healthcare to one of well-being, intuitively as a doctor, and this was an interview with a practicing internist 2 years ago, intuitively as a doctor, that idea of involving patients and families in the knowledge and decision-making about their illness, it resonates. When I build a relationship with my patients, it's not just over their disease, but it's about them and how together we're going to be either preventing or treating the disease. And my anecdotal experience, which I support 100%, would be that the things always went better when they were with me, of course, but also when they were trying to self-manage at home. Remember, they're away from us most of the time. We need to think about how our care plan can be translated into the virtual medical home for them as well as for us to be able to take care of them. We need to be in touch with them through smartphones, through the devices on their wrists or smart speakers. And also, when we visit patients and families in their homes, we enhance the likelihood that they are going to be part of our healthcare team. The next slide is a overview of the diagnostic process, which is laid out by the Institute of Medicine. This is pretty generic for all physicians. And it's a little hard to read, but I'm just going to walk through this with you. On the left-hand side, the arrow, the patient comes experiencing a health, we used to call it complaint. One of the things I try to teach the students these days is to watch the words we use. Complaint immediately sets up, oh, wow, I'm a complainer, versus I'm concerned about an issue that I'm now feeling or something's changed within me. So I encourage the students to use chief concern rather than chief complaint, which chief complaint is still in all the textbooks. It's part of the subtle, old-fashioned way of dealing, the paternalistic approach to dealing physicians to patients. Patient experiences a health problem, engages the health system, and the process is information is gathered, health history and interview starts the ball rolling, a physical exam based on what you find in the history and physical, and I'll digress for a minute, it'll come up later again. About 90% of making a good diagnosis, even in a complex situation, is by talking with the patient. So the history is critical. How to gather it sensitively, how to organize it then chronologically. Then you look on the physical exam for what you're already thinking and increase or decrease the likelihood of what you are thinking is correct. If you need referral and consultation, fine, we'll send an individual off. But I'll just, again, digress. A huge, huge part of the cost of medical care these days is the secondary referral to people, each of whom has an issue that they like to address, and they do it very well. But it's the kind of the old story of the carpenter with a hammer looking for a nail to pound on. When somebody is sent to a cardiologist because they have chest pain, and we really feel that it could be organically related to the heart, fine, they'll take the ball and run with it. I'm not credentialed to do caths, cardiac catheterizations and so forth. But I want to be sure that this is truly in the heart. There's lungs, there's the skeletal system around the heart, and there's the mind, many times of which, under stress, gives us this feeling of pressure and shortness of breath and so forth. And yet I would have to say that many early patients who think they're having heart or lung disease are really suffering the stresses and strains of daily life. And my job as a physician is to try to sort that out in a gentle way and make decisions that don't get them right into the hands of the cardiologist or pulmonologist and so forth. Then you communicate the diagnosis and explain the health problem that is communicated to the patient, plan the path of care. The patient in the system goes through the system, and outcomes are yes or no, patient's better or not. And the next slide really is my big arrow in this, and it's at the point where you're to communicate with the patient. The explanation of the health problem that's communicated to the patient is what is the critical point where you can then take the time. Now, time, T-I-M-E, is the barrier here. And we're all busy, and certainly physicians think they're busier than most because they're not allowed to have the time they need with patients. I'll get to that point more clearly in a few slides. So the old way was the doctor made the diagnosis, decided on treatment, implemented treatment, made follow-up plans, many of which never got done. This is the old paternalistic approach by physicians. I know what's going on. Here's your prescription. Get it filled. I'll see you in 2 weeks. Bye. That isn't the way it works. It doesn't work that way. The new way, my suggested way, and it's not just my way, it's the way that good doctors do interact with their patients. They gather the information as I've described. They conceive of a treatment plan and further diagnostic testing to increase the probability that the diagnosis is correct. Medical diagnosis is always, this is what I think is going on. We're going to do this and that. We may give you something to try, or we need to do a test. Now we'll change. We'll either increase, yes, I'm sure, or whoops, no, something else must be different. So it's a series of likelihood ratios. That's all medical diagnosis is. It's likelihood ratios. Fortunately, 80-90% of the time, we've got it pretty well nailed with that initial interaction and our presumptive diagnosis. Then the physician whose job it is to get that diagnostic concept settled and start the ball rolling, educates his or her team about the diagnosis, the present treatment plan, why it's supported by data, and the team then integrates it and asks the questions because they're now the advocates for the patient, because they're going to have to be interacting more with the patient than the physician. The team decides how best to educate the patient and family, by whom, when, how to implement the diagnostic treatment and follow-up plans when the whole team has had their input in. Now, I'm already seeing the frowns on the faces of the people listening in. Well, who sets up the team? This is a lot of people and so forth. This is going to take time and money, and to allow them to have these meetings, to have those kinds of decisions made. So when one does that, the plans are much more likely to be accomplished based on personal preferences, social, economic factors. I might hand a patient a prescription, but when he gets to the pharmacy, whoa, $200 copay? Wait a minute. I haven't seen $200 in the last month. And bingo, nothing proceeds from that point on. Tremendous savings in time, energy, and costs. So by including, next slide, the family member and patient as team members and colleagues, we gain their input, make appropriate plan alterations, which better fit their preferences, needs, and realities of life. And in the process, we gain their trust. That's the most valuable relationship a physician can have with the patient, which dramatically enhances the likelihood the patients will actually try to adhere to the modified jointly developed plan. Compliance is another word that I talk to the medical students about that immediately sets up the issue. Well, the patient didn't want to do the plan, but adherence is the issue. They couldn't do the plan. They didn't have the money. They didn't understand what the medicine was for, and so forth. So the big difference between using adherence as a term and compliance as almost an accusatory term. Primary care definition. Now, this is where the solution of the dilemma is for the future. Primary care is defined, this was a famous article by Dr. Barbara Starfield, Primary Care Concept. This was 1992. The 4 C's of primary care are contact, which means access. Patients need to be able to get to you. Coordination, which is care management. Comprehensiveness, which is patient management. How well are you able to take care of all the people under your responsibility with these problems? And then continuity. And continuity is what is called the trusted relationship. And that has been what has been taken for granted in our healthcare system, the continuity issue. So the trusting relationship was further analyzed by Dr. Pollack. I'm going to give you my email address, Sheagren@msu.edu, because you need to read this. You need to read this article. Steve Pollack, Pay for Relationships, a novel solution to the primary care crisis. Pay for relationships. what does this mean? In other words, you're going to pay me to develop a trusting relationship with patients? And the answer is yes, because I've already told you that the time it takes to build that relationship is now lost in the shuffle of the 20 to 30 patients I may need to see as an admitting hospitalist, for example, in my shift of 12 hours. There's no time to build that relationship. The trusting relationship. The fourth C, this is now slide 13, needs to be valued, because trust develops after years of thoroughly evaluating problems, understanding patients' individual experience, compassion, empathy, reliability, dependability, etc. Being honest and respectful to each patient that we interact with, and not just saying, well, looking at your watch and saying, well, I've got 3 people waiting in the outpatient area. Let's talk about this next time. Doesn't work. So on to slide 14. The future of medicine will depend on the following. The best medical care, which is highest quality, lowest cost, will be delivered by teams of health providers which build trust by communicating well with patients and families, agreeing on the best care plan for each individual patient, taking pride in skillfully fulfilling each assigned role, because the physician is the diagnostician, but that we need a pharmacy expert sitting there saying, well, wait a minute, this patient has a history of an allergy to a penicillin as a child. Did you know that? But you've subscribed to cephalosporin, which cross-reacts with penicillin. We should not do that. Pick another choice for your antibiotic. Well, okay, thank you very much. At least we don't have somebody who develops hives and trouble breathing with the first pill they took from my prescription. Understands how effectively to assist other team members in fulfilling theirs, especially the patients and family themselves. Value-based medicine. Now, the Affordable Care Act tried to knit value-based care into the framework through a variety of vehicles, including shared savings plans, promotion of medical homes, payment structures, etc., etc. Virtually all healthcare stakeholders now use the language of value-based care as they tout new initiatives and programs. But what exactly is value-based care? The practice of medicine is an art, not a trade, a calling, not a business. Sir William Osler, among his famous aphorisms, listen to your patients. They are telling you the diagnosis. Medicine is a calling in which your heart will be exercised equally with your head. To digress, what's the definition of a profession? The Cambridge English Dictionary, the English seem to be the best describers of the classic definitions. Cambridge English Dictionary says, a profession is any type of work that needs special training or a particular skill, often one that is respected because it involves a high level of education. It needs special training and skill, such as being a doctor or lawyer, but not work in business or industry. Not work in business or industry. So let's talk about the future of medicine, because just to emphasize that last thought, one of the problems with medicine is it has become more of a business than a profession. There's never been more uncertainty in medicine. Definitely something needs to be done. Costs are totally out of control. But in my view, there have never been more opportunities. And this is a slide that was in part of a student lecture. I say to the students, therefore, for now, stick to your objective of being an excellent student in your special groups, because this talk is given to all the students at Grand Valley who are not going to be physicians. They're going to be nurses, physical therapists. At Ferris, they're going to be pharmacists, and I give my spiel to all of them. Be an excellent student in your special group and realize that the time you would be spending with patients, if done well, will Build the trust you need to guarantee success in the care you provide. And I might add, you will uncover issues in their lives and facts of the problems that they're experiencing that the physician may have missed. And when you come back to the team meeting, you will dramatically change the thinking and the course of treatment for that patient. I tell the medical students, in every rotation of students through internal medicine, I would guess at least one life is saved by a medical student who uncovered a fact that was missed in the hustle bustle of getting that patient in the hospital and on the course of treatment. So care for yourselves, care for your patients, and stay healthy in the process. So how do we enhance or create the trusting relationship? That, as was noted earlier, is the neglected part of being a primary care physician. And when I first saw that title of Stuart Pollack's piece, it's in the New England Journal of Medicine. It's actually part of a new series that they're putting out called the Catalyst series of the New England Journal of Medicine. Pay for relationship. I said, what? How can you just give a physician or a team dollars and improve the relationships with patients? And he then put the caveat on it in his title, Pay for Relationship, a novel solution to the primary care crisis. What society should and can pay for its care that enables relationships between patients and providers. Well, most of you probably are saying, oh, now I'm beginning to understand. It's time. So he then went on. The next 3 slides are under the heading of a modest proposal for pay for relationships. I'm sure you all remember the title Modest Proposal, written by an English author, Jonathan Swift. Thank you, Dick. He wrote a piece on how to solve the problem of all the little children running around and causing trouble to the grown-ups. And his solution was, eat them. Unbelievable. Well, Modest Proposal caught my eye, and I thought the proposal might be in that kind of general sarcastic, ironic ilk, but it really isn't. He suggests that the payment process for the team members be better defined, that there be continuity built into the reimbursement, that he then goes into the issue, how do you pay for care outside the usual 5 to 8 weekday hours? Because every patient must have a person who will know them or be covered by somebody who can immediately get to the issues that are in their records, so they don't have to run to an emergency room or an urgent care center and say, oh, I'm short of breath and so forth. And the urgent care center starts the ball rolling all over again at huge expense and actually danger to the patient. So there has to be how care is provided outside the usual 8 to 5 weekdays, how home care visits can be reimbursed. Hospitalists are here to stay, yet many patients feel abandoned when they're in the hospital with a person that they've never seen before. And the local doc may often need to come in to give a sense of what's going on or to fill in the gaps. How payment for the next slide goes into how payment for the members of the care team might be carried out. It's too detailed to go into. And then payment redesign for primary care. New revenue must flow into primary care. You can say, well, but you're telling me we're already spending too much on health care. Where are the extra dollars going to come from? One needs to look carefully at how much work is being done outside of, that's in addition to the primary issue of the patient, and in order to keep that patient continuously healthy. The trusting patient relationship depends on having a person or a small group making the decisions that keep that patient on track without being referred unnecessarily to specialists, without having extra tests done if they walk into somebody's urgent care or emergency department, which will be done by the usual prudent individual there saying, well, I've got to get another chest x-ray. This person's short of breath, et cetera, et cetera, et cetera. But the primary care people who've been following that patient would know, no, we don't need. We had a chest x-ray just 2 weeks ago. We've been all through that. This is our suggested recommendation, and I'll see this patient tomorrow. Or in fact, if you think so, if you think it's necessary, send the patient home. I'll see him first thing in the morning at home. Well, is this possible? The answer is yes. All it will take is shifting money, and this has been brought up. And of course, most people feel that the devil's in the details here. That how in the world can we shift money around in this complex healthcare system? And I'll now make another statement that yes, there's enough money to do what we've just described, but it's got to come from other sources that are presently less efficiently being used. Examples, as you've heard in the discussion, in the political discussions now, do we need all the types of insurance that we're paying for now? What about specialty referrals and so forth and so on? The primary care team is the one to decide what the most efficient way to take care of that patient really is. So I would welcome questions and comments if there were a live audience out there, but I'm going to finish with just 3 personal pictures here because I'm very proud of these pictures and they keep me motivated in my dotage. Here's a picture of a tall gentleman standing next to me. He is my grandson. This is his white coat ceremony when he entered Michigan State Medical School 5 years ago. All the new medical students get a white coat, which signifies the fact that they are in the physician track. This is him 1 year ago as he graduated with his granddad in their academic regalia. And as I said, I'm teaching at Michigan State. However, I owe way more to this beautiful woman sitting next to me and this tailgate at the University of Michigan football game, my dear wife, Victoria, because I was at the University of Michigan for 20 years, still have season tickets, and we do enjoy and support the University of Michigan in their appropriate role, while I support and enjoy my relationship with Michigan State in my role at the present time. So thank you very much for listening.
My friends, thank you for joining us this morning. Thank you to John for his inspiring words, and thank you to Danny Heck for bringing this service together, for Wright for your music, and of course for the Religious Services Committee who curates and makes these services possible summer after summer, week after week. As you leave this time of worship together, remember that even though we are not together in body, and even though we go forth from this worship into our separate lives, and of course our separate worlds, we are united and bound together in spirit. And in that sense, we are one and together until we meet again. Go in peace, stay healthy, and remain resilient, my friends.
Thank